Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello, everyone, and welcome to this special edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community, and our goal is to spark conversation, ideas, and action. Since we are live, I want to remind everyone how to ask questions of the presenters. Since the audio lines are muted, we don't take questions over that line. However, you all have the opportunity to type your questions into the question box at any time, and we'll check for questions at the end of the session. Please don't feel you need to wait until then to type your questions in. Just put them in as you think of them. We're delighted to partner today with the Canadian Paediatric Society to bring you this very timely webinar, Paediatric Inflammatory Multisystem Syndrome and COVID-19, what Canadian healthcare providers need to know. We are joined today by colleagues from our member organizations, the Hospital for Sick Children, Montreal Children's Hospital, Saint-Justine, and the Children's Hospital at London Health Sciences Centre. For those of you on Twitter, please tag us at ChildHealthCan to any webinar-related tweet and share away. I'd like to welcome our guest moderator for today, Dr. Ray Young. Dr. Young is presently Professor of Pediatrics, Immunology, and Medical Sciences at the University of Toronto and a Senior Scientist in Cell Biology Research at the Hospital for Sick Children. Dr. Young is currently the Chair and Principal Investigator of UCAN, Understanding Childhood Arthritis Network, and Chair of the Scientific Committee of the International Kawasaki Disease Genetics Consortium. In addition, Dr. Young was the founding chair of CAPRI, the Canadian Alliance for Pediatric Rheumatology Investigators. It's my pleasure to pass the mic to Dr. Young.
Good morning, everyone. Delighted to be here and delighted to be welcoming you to this seminar. Just confirming with the chair, Paula, that we are that you are able to see my screen. Thank you very much. Good morning again. We're excited to be joined this morning by colleagues from around the country to really share some experience in this very rapidly evolving field of a syndrome that has multiple names. In the introduction, you heard one of the names, Paediatric Multisystem Inflammatory Disease. It's also known as a hyperinflammatory syndrome temporally associated with COVID, as well as MIS-C. Others have called it Kawasaki disease-like syndrome. In a nutshell, we're going to be having an overview of this syndrome complex. Dr. Rosie Scucciamari will be giving us an overview. And then we're going to be sharing some experience from one of the centers that has had the most patient experience with this evolving disease from Saint-Justine. And Drs. Ellie Haddad and Mary Paul Moran will be sharing their experience. We're going to be ending by some practical take-home messages from Dr. Roberta Berard, who will be sharing information for our many colleagues from around the country, and then end with some summary points as well as action items as we go forward. We thank you very much for saving your questions until the end, and I will try to moderate. And if you can just enter them on the electronic session, it would be very much appreciated. So without any further ado, I'd like to introduce the first session. and Dr. Rosie Scucciamari, who is an assistant professor at the McGill University. She's a pediatric rheumatologist in the Department of Pediatrics, and Dr. Scucciamari has a long-standing clinical and research interest in Kawasaki disease and was the co-lead on the CPSP Kawasaki disease study from several years ago. Dr. Scucciamari.
Thank you for the invitation from the Children's Healthcare Canada and the CPS for allowing us to talk today. Seem to be having some problems moving my screen. I apologize. Okay, here we go. I have no disclosures for this talk. So for my outline, I'll go through a history of pediatric inflammatory multisystem syndrome. I'll discuss the relationship between PIMS and COVID-19, and I'll go through the various case definitions for this entity. So all this started in late December, early January, when a large number of pneumonia cases were reported from Wuhan, China. On January 9th, 2020, coronavirus was identified as a causative agent. On April 7th, 2020, the first case report of a child with Kawasaki disease co-infected with COVID-19 was reported. However, it wasn't until April 27th when the medical community was alerted about this through the UK health authorities, when they reported a cluster of seriously ill children presenting with shock and an inflammatory state. And they described these as Kawasaki disease-like or toxic shock syndrome-like. On May 1st, the Royal College of the UK coined the term Paediatric Multisystem Inflammatory Syndrome temporally associated with COVID-19, and they provided a case definition and guidance. On May 6th, the first initial cases from the UK were published in The Lancet, and Dr. Berard will go through these cases in her presentation. Throughout early May, a number of reports of increased cases in Italy and France, and their cases were reported as far back as March and April, and other parts of Europe also seeing an increase in these cases. It wasn't until May 3rd when it appeared, reports of this appeared in the media at St. Justine Hospital with 12 cases of atypical Kawasaki disease. So this is the first cases that were described in North America. On May 4th, the day after, the New York City health authorities described 15 cases that had presented in the last 2 weeks. And these children had features of typical Kawasaki disease, incomplete Kawasaki disease, and shock, and they aged between 2 and 15 years of age. A large proportion of them had rash and gastrointestinal symptoms, and greater than 50% required blood pressure support. A third required mechanical ventilation. At that time, there were no fatalities, and some tested positive for COVID-19 through PCR and other through antibody serology. On May 9th, the media reported 3 fatalities in New York City: a child of 5, another child of 7, and 18. And in Europe, around the same time, another 2 or 3 fatalities as well. May 12th, the media reported over 100 cases in New York City of this entity and other clusters in other areas of the United States, mostly on the eastern seaboard. On May 14th, the CDC provided a case definition. On May 15th, the WHO provided a case definition. And on May 23rd, up to 161 cases were reported through the surveillance program in New York City. In regards to the relationship between PIMS and COVID-19, we need to look at public health data. This is an example from France, and their epidemiological data suggests that PIMS occurs approximately 4 weeks following COVID-19 infection. If we look at one of the sides, we can see that the number of hospitalizations to one side of all cases of COVID-19, and on the other side, we can see the cases of the Kawasaki-like illness. And in the middle, in red, we can see the peak of the number of cases of COVID-19 was around week 13 in France. And if we look at the number of cases of the peak for the Kawasaki-like illness, it was week 17. So they suspected that it took about 4 weeks to get this peak. So there may be 4 weeks following a COVID-19 infection. If we look at the relationship with testing, There's, in regards to COVID-19 PCR, the numbers are lower. However, when we're looking at antibodies, there's a relationship between the cases already reported. We have a number of cases in London, in Italy, and France that have been reported, and we can see that the antibodies of COVID-19 in these children are between 80 and 100% positivity. And most of them are the IgG subtype, which is suggestive of a previous infection of at least 7 to 10 days prior. So certainly we're seeing that there is a relationship with having had COVID-19 infection. This is a distribution of coronavirus cases in Canada as of May 14, 2020, by age group. And we can see that children 19 years and younger have been less affected compared to the rest of the population. And there's about approximately 5.66% of cases that are in this age group. And this is the group that are at risk for PIMS. However, we have to put this in perspective. This is a rare entity. And if we compare this to the influenza virus, there's a case fatality of more than 130 children in the United States in last year that for influenza. So we do have to remember that this PIMS is a rare entity. However, it is an important one, and children are at risk. The etiology is certainly still unknown. It's suspected to be a post-infectious inflammatory syndrome. There's a temporal association, as I've shown you, with COVID-19 infection and the pandemic. There's no evidence of ongoing viral replication in children, and there's presence of IgG antibody. We feel it's characterized by some sort of immune dysregulation that occurs approximately 2 to 4 weeks post the primary infection. There's likely a role of genetics. However, this still has to be elucidated. What's also not clear is whether this is Kawasaki disease or a novel Kawasaki-like illness characterized by multisystem inflammation. A lot of the cases that are describe children presenting in shock, presenting with macrophage activation syndrome or myocarditis. All these entities have been previously described in Kawasaki disease. So is this Kawasaki disease, but a more severe end of the spectrum, or is this a novel illness? And that is still not clear. To understand this, it's important to also understand Kawasaki disease. Kawasaki disease is a febrile illness that's characterized by changes in the peripheral extremities, a rash, conjunctivitis, changes in the oral cavity, and cervical lymphadenopathy. I think it's always easier to see it in pictures. So the oral changes are described as strawberry tongue, cracked lips, swollen lips. You can have a large lymph node, as you can see in the top picture in the middle. It's usually cervical and greater than 1.5 centimeters. Children often have a rash. It's polymorphous. And the top right pictures, we can see the hands and feet that are erythematous, that can be swollen, and then a bulbar conjunctivitis that presents in both eyes. This entity has also been described as a toxic shock-like syndrome. So what is toxic shock? How does it appear? Certainly, it has some features that are similar to Kawasaki disease. Fever, rash, mucous membrane involvement, those are similar to Kawasaki disease. However, toxic shock can present with hypotension, as can Kawasaki disease. Kawasaki disease presents with something called Kawasaki shock syndrome, and can be present in up to 7% of cohorts. And in toxic shock, there's a large proportion have gastrointestinal symptoms, and they can also have central nervous system symptoms. Certainly, with this entity of PIMS, we're hearing a lot of gastrointestinal symptoms as well as some central nervous system symptoms. So it's important to understand this phenotype. The Royal College in the UK produced this case definition on May 1st. They termed, as I said, the use of the term Paediatric Multisystem Inflammatory Syndrome temporally associated with COVID-19. Their case definition was a child presenting with persistent fever with evidence of inflammation, either by elevated CRP or neutrophilia, and evidence of single or multi-organ dysfunction. They've also published an appendix of what additional features you may want to look for. And they said that these children may have fulfilled partial or full criteria for Kawasaki disease. It's important to exclude other causes. And for this case definition, for reporting in their surveillance program, it was not required that SARS-CoV-2 PCR testing was positive or negative. The appendix that they published showed that children had significant gastrointestinal symptoms, had features of Kawasaki disease, features of shock, and certainly in terms of the laboratory work, which Dr. Berard will go through in more detail, was suggestive of a significant inflammatory syndrome and some features of what we call cytokine storm syndrome or macrophage activation syndrome, which again, Dr. Berard will go through a little bit more in detail in her presentation. On May 14th, the CDC put out their own case definition. They used the term multisystem inflammatory syndrome in children associated with coronavirus disease. In their case definition, an individual aged less than 21 years of age would be included. They had to have fever, and their fever was for greater or equal to 24 hours. They had to have evidence of inflammation, and they had to have a severe illness requiring hospitalization. With their definition, it has to be multisystem with at least 2 organ systems involved, either cardiac, renal, respiratory, hematological, gastrointestinal, dermatological, or neurological. Again, no alternative plausible diagnosis. And here, there was a requirement for positive either contact or exposure with COVID-19 or positive serology or PCR. The following day, on May 15th, the WHO put out their case definition, and they included children and adolescents between the ages of 0 and 19. Their definition for fever was greater or equal to 3 days. And children had to have 2 of the following: either 1, rash or conjunctivitis or mucocutaneous inflammation; 2, hypotension or shock; 3, involvement of the myocardium or coronary vessels; 4, evidence of coagulopathy; or 5, acute gastrointestinal symptoms with evidence of marked inflammation, with no other causes for this inflammation, and evidence, again, for COVID-19 infection, either by serology, PCR, or a significant contact with COVID-19. The CPSP put out their definition last week, and it includes any new patients less than 18 years of age who meets the following criteria. The children have to be sick and therefore hospitalized, and they had to have persistent fever for greater than or equal to 3 days, elevated inflammatory markers, and one or both of the following: features of Kawasaki disease, complete or incomplete, or features of toxic shock syndrome, complete or incomplete. Certainly, the feature of toxic shock was to encompass the shock features, the gastrointestinal symptoms, and the central nervous system symptoms that have been described, and no alternate etiology to explain these. However, the CPSP did not require positive serology or PCR or contact with SARS-CoV-2 status at this time. Here's a summary of the different similarities and differences. The terms are different, each different. The length of fever that for all was specified. The yes is greater than 3 days. These is greater than 24 hours. Part evidence of inflammation, other causes, both are multi-system. that it could be single or did not that it was implied. And again, it's our antibody. It
Hi,
was
Rosie. I think we're having some audio difficulties.
UK Royal College and the CSC, and it was required for the CDC and WHO. I think I'm having some problems with the audio. 1 second. So in conclusion, since April 2020, a pediatric inflammatory multisystem syndrome emerged with the COVID-19 pandemic. There's a clear temporal relationship with SARS-CoV-2 infection. It's still unclear whether this is a spectrum of Kawasaki disease or a novel multisystem inflammatory syndrome. To better understand and characterize this entity, multiple surveillance programs are underway, including one with the CPSP, and it's important to report your cases. Thank you.
Thank you very much, Rosie. This is thank you for giving us this wonderful overview of the development and really the of this disease and the international perspective. Now we're going to switch the lens a little bit and join our colleagues from St. Justine, Drs. Ali Haddad and Marie-Paul Moran, who will share their experience and the lessons learned from Canada's first cohort of these hyperinflammatory syndrome. Dr. Ali Haddad is a professor in the Department of Pediatrics at the University de Montréal and currently the head of the Immune Disorders and Cancers Research Axis at St. Justine Research Center. Dr. Marie-Paul Moran is an assistant professor in the Division of Rheumatology and Immunology at St. Justine Hospital and building up one of the newest units in pediatric rheumatology in the country. So welcome, Drs. Haddad and Moran.
Hi, everybody. Do you hear me well?
Yes.
Yes, okay. Thank you. Thank you, Ray, for the introduction. I'm together with Marie-Paul Morin, and I would like to thank on the first slide the help of Camille Beaufils, who is a fellow in our unit and who did a great job with a very short notice to help us to put this together. So indeed, we have a great big epidemic here, big pandemic here in Quebec, and we were facing cases, and we decided at the beginning to include every patient that were weird. And we had 33 patients between the end of March until the end of May yesterday. And we decided to include Kawasaki disease, atypical, incomplete, unusual inflammatory syndrome, or any condition. And then we reviewed yesterday, actually, all the patients with the various international criteria. And by the way, I prefer the last one, the one of the Canadian Paediatric Society. I just love them. I think they're accurate. And at the end of this filtration, we ended up with 19 patients that fulfilled the criteria and 2 that were uncertain. We excluded 2 lupus, 2 with PAN, which is weird. You know, we don't have frequently 2 PAN in the same month, but because there is an alternate diagnosis we excluded. 2 with autoimmune encephalitis, 2 patients with proven other infections, which were bacteria in both cases, actually. 1 with symptoms beginning in December. We had a tough discussion about that, but we said, no, it's very unlikely. 1 with a fever, but actually it was not a fever. 1 with a pre-existing history of repeated or periodic fever. So because the fever began before the COVID infection, we say, no, it's not possible. And 1 with that was just a mistake. It was just a polyarthritis. So now that we have our 19 patients, how do we distribute? We have 5 classical KD, 3 incomplete, 6 atypical, 4 TSS/myocarditis, 1 other, and 2 uncertain. I'm going to show you a little bit more in detail the case. So classical KD, nothing to say except that it's a classical KD, more males. None with GI symptoms. The inflammatory syndrome was around 80 for the CRP. We just had 1 dilatation. And interestingly, regarding the treatment, only 1 could be treated by IVIG alone. 2 required IVIG plus steroids. 1 required 2 times IVIG. And 1 required 2 times IVIG plus steroids. Regarding the incomplete KD, so patients missing all the criteria, nevertheless, all had fever and rash, actually, no GI symptoms again. The inflammatory syndrome was a little bit higher than in the classical Kawasaki, let's say, although it's small numbers, so we cannot have conclusion. And 1 had coronary artery dilatation. It's in French here. And the Z-score was 4. Again, one needed IVIG plus steroids, only one IVIG alone, and one had nothing because it was diagnosed a posteriori, actually, when we looked at the file. And without treatment, the evolution was okay, which is interesting. Then there is the patients with atypical KD. We have 6. Why were they atypical? Because 3 were over 5-year-old, 8, 12, and 14 years old. One was below 1 year old, and we had for some patient pleural effusion. One had that macrophage activation syndrome. Only one among this cohort had GI symptom, which is obviously unusual in Kawasaki. One had neurological symptoms. The inflammatory syndrome ranged between 50 and 260. 2 patients had coronary artery dilatation with a Z-score written here. And one, again, had a good evolution without any treatment. Actually, we were waiting for the bone marrow in order to be sure it was not a leukemia, and spontaneously, the macrophage activation syndrome resolved. And when we look back the file, he had the criteria of a macrophage activation syndrome, which is surprising, but that's the way it was. One with just IVIG, one with just steroids, and 2 patients requiring more than IVIG or the steroids. And here, 1 patient with 2 times IVIG plus steroids. So it can be it could be severe case. Interestingly, we had 4 patients with the myocarditis, TSS, or Kawasaki shock syndrome. 3 were severe, and 1 had just an isolated myocarditis. You could discuss whether it should be included in our series, but in the French definition, you could. So 3 out of 4 had fever, 1 out of 4 had rash. In this cohort, we had GI symptoms, and 1, interestingly, had surgery for what we thought was appendicitis, but actually it was not. It was normal, and this patient had a shock and required to be filled. They don't look like KDs, clearly, and they can be very impressive from a clinical point of view. And the inflammatory syndrome range between 30 and 300 just for the CRP. 2 required ICU. Almost 3, the one who was not in the ICU, we just, by giving steroids high dose, stopped the indication of transferring to the ICU because the patient improved like dramatically and very rapidly. No coronary artery dilatation in those 4 patients. 2 required amine, or I don't know how you say this in English. In French, it's amine. 3 required to be filled. Interestingly, all of them had increased troponin, and troponin was the target of asking the cardiologist in 2 of them, and 2 had pericarditis. 1 was treated with IVIG and steroid, 1 only IVIG, 1 just with a non-steroid anti-inflammatory drug plus colchicine, the one who had myocarditis, and 1 nothing, meaning that it was the appendicitis just by the treatment by amine and the feeling she was much better, and then she was okay. We had 1 patient we don't know how to classify, 2.5 months, very young, fever, rash, respiratory symptom requiring ICU for a short period, very inflammatory, dactylitis, steroids, and then it was okay. And then 2 patients, we don't know what to do with them, if we should include them in a new disease with new definition that nobody agrees on, so it's complicated to say. 2-year-old boy, fever, very high CRP, dilatation, pericarditis. We hesitated because it's not clear if he had or not fever episode in 2019, so we don't know. And a 3-year-old girl with rash, fever, adenitis, aseptic meningitis, high platelets, and she did better under steroids. I will end with 2 slides of take-home message from our clinical point of view, what we are seeing and what are our message. First, epidemiologically, we can say that it's 3 or 4 times more frequent as compared to our history in our hospital. And I am here now for 15 years, so really there is something strange happening. Many, I would call them weird, atypical cases. I cannot find a better adjective with my poor English than weird. They can be impressive and misleading. This is very important to remember. But we have a good point, is that IVIG and or steroids are very efficient if you give them fast. We do consider that we have to involve the cardiologist 100% of the time. We've been surprised to see, for example, increased troponin. And we consider that troponin has to be done because it's not a usual thing we do in pediatric, obviously, but here it's very helpful. There is the question of what is the norm of troponin. This I know, but still, it's very interesting in this context. The difference with the literature, we don't have so many GI symptoms that as reported, and we didn't face so many severe cases. Maybe because we were very aggressive and fast with IVIG and steroids. Okay, this is to glorify ourselves, but maybe it's more the epidemiological aspect. We had only 2 patients from a Black African American ancestor, and the 2 were severe actually, which is interesting, but not enough patients to make any strong conclusions. And also we've heard of people called us to have opinions on several cases in Europe or New York City by friends in immunology and rheumatology, and some cases needed to be treated by tocilizumab and or anakinra, and we heard that there were cases that were very difficult. And my last slide is, in all cases, we said to ourselves when we saw the patient, it's sure it's COVID, it looks like COVID, and we never found it. Then we gave up. And then when there was this announcement that maybe there are patients with post-inflammatory disorder, we said, okay, that's maybe this. And I would call this, in my language, a rare inflammatory condition during a pandemic. That's the only thing that I could say here. And I think I consider very strange to already have criteria of something that we still don't know. This is weird for me, but okay, let's put criteria. So the key question here is, are you sure, Dr. Haddad, that it's the COVID-19 related? And that's why I like the definition of the CPSP. First, I'm sorry, I can't disclose yet the serology data because they are still in process, that we are still analyzing, and we need to have the good controls, and we don't have yet. And it's funny that serology can be in the criteria because we don't have access to it in a clinical lab. So we are dealing with research lab. And as you may know, research labs are not the top lab to be sure of the data. They don't work the same way as clinical labs. So it's difficult to disclose the data as long as we don't have all the controls. We think that it's COVID-19 related, but that's the only thing that we can say now. So thank you for your attention, and we will be open together with Marie-Paul. That it was together that we said I would be the only one to speak. I was not speaking.
The second to get the, oh, there you go.
Yes. So thank you very much for your attention, and thank you for giving us the opportunity to present you our series.
So thank you very much, Dr. Haddad, for sharing your experience and sharing these lessons. I'm sure there's been a lot of questions posted already, so we will look forward to the discussion, more fulsome discussion at the end of the presentation. So our next presenter is Dr. Roberta Berard, and Dr. Berard is an assistant professor of pediatrics at the Western University and the head of the Division of Rheumatology at the Children's Hospital, London Health Sciences Centre. Bobby's main clinical and research interests are in juvenile idiopathic arthritis, in models of care and uveitis, and has an extensive experience also in dealing with inflammation and Kawasaki disease. So, Dr. Berard.
Thank you very much, Ray. You can hear me, yes?
Yes, very well.
Yes,
thank you.
Perfect. Thank you. All right. Well, thank you very much to the organizers for inviting me to present on this topic. I can't advance my slides. Yes, I can. Okay, I have no disclosures relevant to this presentation. So my objectives over the next 15 minutes will be to provide an overview of PIMS, including clinical presentation, and consider diagnostic workup to be considered, to review the red flags for when a clinician should refer to subspecialty care or transfer to a tertiary care center, and to discuss potential therapeutic algorithms for PIMS. So as you well know, this is a rapidly evolving situation, and first case was described 6 weeks ago. And what was once thought that COVID would be a mild illness in children, this is ultimately proving to be potentially the bigger problem. And these alerts have created a lot of excitement in the media. So this is one case of a 14-year-old boy who became sick over 10 days with lymphadenopathy, fever, severe abdominal pain, and myocarditis presenting in heart failure. A baby in the UK dying with classic KD and dying of a ruptured aneurysm. And then finally, a young girl who had severe fulminant myocarditis with abdominal pain presenting in toxic shock. So what I'm going to review for you now is what we have from the first early scientific publications. So there's 3 papers that we will discuss. The first is of 8 children with hyperinflammatory shock in the UK, then 10 children with a Kawasaki's-like illness in Italy, and finally 17 children with a Kawasaki's-like illness from France. So the first case series is from Southeast England, where they serve a catchment area of around 2 million children. And they described 8 children aged 4 to 14 years that were admitted with hyperinflammatory shock over a 10-day time period, during which time they would normally see 1 or 2 cases of Kawasaki's associated shock, or toxic shock. In this 8 children, 75% were Afro-Caribbean and 62% were male. There was 1 death. The clinical features that were noted from this 8 children were unrelenting fever, rash, conjunctivitis, peripheral edema, generalized body pain, severe GI symptoms, and vasogenic shock. So as you've heard before, there's features both of KD and of toxic shock. These children exhibited laboratory parameters of lymphopenia, elevated neutrophils, elevated D-dimers, troponins, markedly elevated CRPs, elevated ferritin, and hypoalbuminemia. They all tested positive for COVID-19 antibody testing and were negative for PCR. From these 8 children, they received supportive care, antibiotics, and inotropes, and 5 of 8 were intubated. They all received IVIG, half methylprednisolone, and 1 out of the 8 received infliximab for severe coronary artery dilatation. The second publication is with regards to a severe Kawasaki's-like outbreak in Italy, in the epicenter in Bergamo. And what they did is they described all patients that they had seen over the past 5 years with Kawasaki's disease. And they divided those into 2 groups, a pre-pandemic group, which described 19 patients over 5 years, and a pandemic group, which described 10 patients over a 2-month time period. And in these case series, 8 out of 10 were positive for serology. So what they found was that overall, these were sicker patients than what they typically would see for Kawasaki's. So the pandemic group, they documented a 30-fold increase in Kawasaki's disease, 10 versus 0.3 per month. They were older children with a mean age of 7.5. The cardiac involvement was significant, with 60% in the pandemic group versus 10% in the pre-pandemic group. The cardiac involvement included reduced ejection fraction, 2 with aneurysm, pericardial effusion, and mitral valve regurgitation. Furthermore, Kawasaki's disease shock syndrome, which is characterized by hypotension and hypoperfusion in Kawasaki's disease, was seen in 25% versus a typical 5% in other cohorts. Macrophage activation syndrome similarly was seen in 5 out of 10 patients, and there was a need for adjunctive steroids in 8 out of 10 versus 2 out of 19 patients. So when we looked at the labs for these described patients, they had 50% were incomplete KD, and although it did not reach statistical significance, the CRP in the pandemic group was 250 average versus 160 in the pre-pandemic Kawasaki's groups, demonstrating this significant elevated CRP, which seems to be a common feature of this novel condition. There's also neutrophilia, low lymphocytes, low platelets, hyponatremia, and elevated ferritin. Then we have evidence from another outbreak of Kawasaki's disease from the Necker Hospital in Paris, France. And from this, they did a Poisson regression, and what they demonstrated was a 13-fold increase in incidence of Kawasaki's disease, where they saw 17 children admitted with this condition over 11 days in April. Again, these children were older. There was an overrepresentation, seemingly, of African ancestry in these kids, with 60%. And the question begs if that's an adverse social or living conditions or a genetic susceptibility. Again, they had marked GI symptoms in this group of patients, some 3 with peritoneal effusions and 2 with acute surgical abdomens. Again, the vast majority were positive for COVID antibodies. And furthermore, these again were sicker patients than typically would be seen. They all received IVIG, 30% additional corticosteroids. There was a third of patients that had coronary artery dilatation, and 3/4 of these patients were admitted to the ICU with either myocarditis or Kawasaki's shock syndrome. So from the publications to date, what we know is that there seems to be an apparent marked increase in the incidence of Kawasaki's disease over the last couple of months. The kids that are presenting are older. There seems to be an overrepresentation of Afro-Caribbean and African American ethnicities. There's a prominence of GI symptoms, and there is an increased disease severity. So when we look at a direct comparison, again, we've highlighted many of these features between Kawasaki's disease and PIMS. What I want to highlight is that in the literature to date, you will notice there's an absence of reports from Asia, which has obviously been hardest hit with COVID. And we have been hearing more about this Afro-Caribbean, African-American ethnicity potential predisposition. And then finally, this marked predominance of gastrointestinal symptoms reported in the literature, in addition with cardiac dysfunction, coagulopathy, shock, and macrophage activation syndrome. Furthermore, what we have seen is that the CRPs in PIMS are markedly elevated and out of keeping with the elevation we see in ferritin. And normally in other cytokine storm syndromes, like macrophage activation syndrome, they're both significantly elevated. Obviously, when possible, there has been evidence of cardiac dysfunction through biomarkers, thrombocytopenia, and elevated D-dimers. So when we talk about the spectrum of what we're seeing in terms of post-COVID inflammatory syndromes, there is the description of patients with fever and inflammation without other clinical features. Of course, we have heard about Kawasaki's disease, which can be complete or incomplete and complicated by shock or macrophage activation syndrome, and then PIMS, which has some clinical features of Kawasaki's disease, but we may see this profound cardiac dysfunction, neurologic symptoms, GI involvement, shock, or cytokine storm. So when we are talking about cytokine storms, I wanted to highlight that this is an umbrella term to reflect a defective immune regulatory mechanism, which leads to hyperinflammation, which results in end organ damage. So this is called different things depending on from which lens you're looking at it. So if it's a genetic predisposition to cytokine storms, we call it familial HLH. If this is seen in the context of infection, which the prototype would be EBV related, that's EBV associated HLH. When we're talking about rheumatic disease, the classic one we think about is systemic arthritis associated MAS, but of course Kawasaki's as well. So the clinical features of cytokine storms are fever, hypotension, rash, often lung, brain, kidney, and liver, pictures of DIC, cytopenias, massive inflammation with ferritin elevations, and where possible, immune activation markers, including soluble IL-2 and other cytokines. So as this is a rapidly evolving situation, of course, so is the proposed workup and possible management options. So I'm going to present some general principles to be considered. So when we're having cases of complete or incomplete Kawasaki's disease, would suggest routine Kawasaki's disease labs per your institution's policies, but to consider adding upfront ferritin and troponin in these patients, given they appear to be sicker than what we typically would see. Specifically, looking at these kids with fever of greater than 3 days duration with some features of PIMS, you would want to do some screening laboratory testing, including CBC and differential, CRP, liver enzymes, electrolytes, albumin, ferritin, and creatinine. When the screening results demonstrate evidence of hyperinflammation, which suggested of CRP over 50, plus one of the other features of neutrophilia, low lymphs, low platelets, elevated ferritin, hypoalbuminemia, or hyponatremia. In that instance, one could consider that from the previously reported literature, the CRPs have all essentially been over 100, but what threshold of CRP should trigger concern is still up for debate. But if you're seeing evidence of hyperinflammation, you may want to consider doing cytokine storm labs, which would include all above, plus LDH, fibrinogen, and D-dimers, as well as troponin, CK, and an ACG. If there's fever of any day duration plus evidence of shock, which would include tachycardia, hypotension, and multi-organ dysfunction, that would be initiating prompt referral. So this is a flowchart of some potential management considerations for these patients with PIMS. Shock patients are not presented on this chart and would obviously prompt immediate referral to tertiary subspecialist ICU care. So if we look here at the top, if we have a child with fever with greater than 3 days duration, with or without clinical features of PIMS, we would want to exclude other causes, do a COVID swab, and where possible, COVID serology, and then perform our screening PIMS blood work. So if we go down on the pathway to the left, if we look at complete or incomplete Kawasaki's disease, we would then follow the protocol for Kawasaki's disease, which would include IVIG plus aspirin. If the fever persists or reoccurs, you could consider a second dose of IVIG. And in light of the fact of this marked increase of Kawasaki's, some institutions are considering prompt second treatment being with steroids to preserve IVIG supplies. In addition, some centers would refer to rheumatology, for example, after first IVIG failure, some after second. So you could consider referral for treatment failures in Kawasaki's. Also, early steroids should be introduced if the child is under the age of 1, if they present with prolonged fever upwards around 10 days, if there's Kawasaki's shock or signs of MAS. Obviously, those would also prompt referral to rheumatology. Kawasaki's can be complicated by macrophage activation syndrome, in which case you would consider steroids plus or minus anakinra, and also would refer. So now if we're looking on the right-hand side of the screen, if you've done your screening blood work and there's evidence of PIMS hyperinflammation, which we highlighted on the previous slide with some of these features, you would then look for evidence of other end organ damage. So if there's evidence of cardiac involvement with abnormal troponin, BNP if you can get it, or low BP, you're going to want to refer, get an echo, steroids, possible anticoagulation, plus or minus IVIG, plus or minus anakinra. If there is severe neurologic or GI symptoms, again, you would consider referral, echo for other organ involvement, steroids, and IVIG also to be considered. So if you have evidence of hyperinflammation, but no evidence of end organ damage, this puts you in the bottom right corner where you're these febrile children with significantly elevated inflammatory markers. And in that instance, we would suggest close follow-up, repeat labs, consider admission, and consider echo, particularly if prolonged fever, plus or minus. No close follow-up and repeat labs for evolution of symptoms. So the management is guided by clinical picture. Inflammatory syndrome, possible cautious observation, plus or minus echo and IVIG. Complete or incomplete KD, treatment as per usual protocol, but with the consider referral to rheumatology. If PIMS with evidence of either cytokine storm, severe end organ dysfunction, or shock, you would consider steroids and referral. So take home points from this part of the talk with me. There's clear wide spectrum presentations of post-COVID inflammatory syndrome. While this is rare, clinicians should be aware of this potential syndrome and maintain a high identified cases. Serial clinical and laboratory assessments with tertiary care multidisciplinary involvement are suggested for severe presentations. And another point to consider in patients with PIMS, to consider echocardiography in follow-up, even if there's no cardiac disease at onset, because we don't really know what percentage of children will develop aneurysms. I would like to thank very much talks last week, a great discussion. Thank you.
So thank you very much, Dr. Berard, for that wonderful presentation and summary and practical take-home points about this evolving syndrome. Wanted to take this time to really thank all of our speakers for really taking up the challenge of sharing their knowledge about this very rapidly developing syndrome complex that we're seeing in the kids that we look after. Wanted to take the next few minutes to just really reflect on some of the lessons that we've learned, as well as to talk a little bit about some of the efforts that are going on at the CPS in terms of data gathering. So where are we now, and what have we learned in really about the 4 or 5 weeks that we've known about this syndrome? The first thing that I think a take-home message from the many speakers from today is that this is really a post-inflammatory hyperinflammation syndrome. It has multiple different names, and which really reflects really the developing knowledge in this area and the many different lessons that we are learning in this very, very early days of this syndrome complex. We know it has features which are consistent with Kawasaki disease. It has features that have been named in North America, MIS, which is a multisystem inflammatory syndrome in childhood. PIMS in the EU, and our British colleagues have called it Paediatric Inflammatory Multisystem syndrome. But all of it is temporally associated with COVID-19. We also recognize that this is a very wide spectrum of clinical disease, with the MIS and PIMS features being the most severe, including shock, cytokine storm syndrome or macrophage activation syndrome, and multi-organ involvement. There's an intermediate phenotype, which is also quite severe with different spectrums, including which ranging from typical features of Kawasaki disease to incomplete features of Kawasaki disease, as well as some with extreme phenotypes of having KD shock, as well as Kawasaki disease with macrophage activation syndrome. There's also the children who have fever and biochemical signs of hyperinflammation, and you've heard about the markedly elevated CRPs and otherwise well-looking children that do not have multi-organ involvement. So really quite a wide spectrum of this hyperinflammatory response, pointing to really the common denominator of massive immune activation as being the underlying feature in the syndrome complex. We've also heard about the importance of having serial clinical and laboratory assessment and for close follow-up of these children who are suspected of having this illness, because of the unpredictable nature right now of the inability to identify which children are going to progress to more severe disease. We heard about the need to monitor for macrophage activation syndrome and to include in amongst your inflammatory screening and Kawasaki disease screening measures of ferritin, D-dimers, and cardiac function, including troponin, and if available, BNPs. We also heard that children, actually, the good news in this COVID cloud is that they respond to conventional treatment for Kawasaki disease, that by and large, children respond to IVIG, they respond to steroids, and they respond to IL-1 blockade with anakinra. We also heard that there are some children, despite being extremely ill and only receiving supportive care, actually recovering well without immunosuppressive therapy. But we also heard that this is really a disease that affects multiple organs, requiring multiple subspecialties to care for, and that we need to remember the cardiac status, both not only during the acute stage, but also in follow-up, and also bear in mind the risk for thrombosis in these children, and the unusual presentations affecting multiple other organs, especially the GI presentations that need to be part and parcel of our initial assessment as well as our follow-up plans. What is humbling about this area is that there are probably much more unanswered questions than there are answers to these particular illness, and that it's really by learning rapidly in this era that we're going to be able to answer these questions. So just very quickly, we already heard, is this really Kawasaki disease triggered by SARS-CoV-2, or is this a novel syndrome? What are some of the predictors for progression to severe disease? What's the role of genetics? What's the optimal treatment approach? And what are our thoughts about long-term cardiac outcome? And if this is a dysregulated immune response that's antibody-mediated, as is suggested from the UK data, what are the implications for vaccinations in these particular populations? So again, many questions, and we are in the early days of our learning journey right now. So where are we going as a community? I think that it's clear that we need data to guide our understanding, that we need more than just social media or lay language literature, which far outweighs actually scientific literature right now. The need to do this together collaboratively and to collect data is critically important. So as part of that push, the Canadian Paediatric Surveillance Program and the CPS, together with the Public Health Agency of Canada, is launching a COVID-19 surveillance. This will include not only hospitalized patients with acute COVID-19, but also this newly described syndrome complex that you've just heard about today in our hospitalized patients. The need for harmonizing this and having a very large catch-all for this is critically important. And as Dr. Haddad mentioned, it is not, none of these case definitions from around the world are perfect. The CPSP has tried to cast a wide net so that we are collecting as much of the raw data as possible to be able to harmonize and work together with our international colleagues to learn as much as possible, as rapidly as possible in these circumstances. So I'd like to just end and move on to the question and answer period by just thanking all of our speakers and thanking our audience for your attention, and also to thank you in advance for reporting. This survey will launch tomorrow, so please stay tuned. Now I'm going to move on to the question and answer period. There's been quite a number of questions and questions that have been submitted. We only have time for a little. I'm going to ask all of our panelists to please turn on their microphones and just ask in particular, there are some questions from the audience with regards to referral for echocardiography. What are the criteria for this? And in anticipation of winter coming, although a number of months away, what criteria other than fever for 3 days should constitute a referral to a tertiary care center for evaluation? Can I open it to the panel? Maybe Dr. Haddad, would you like to comment?
We begin with a tough one, actually. Because the question is when to refer to because if we say that we're going to refer all the fevers more than 3 days during the fall or the winter, it's going to look like a crazy answer. Nevertheless, we have seen that it can go fast. So it depends what you have access to, what you can do, and what are the biological markers, what are your clinical feeling of the patient. Again, they are all weird. I don't know how to explain that better. They don't look like the patients we used to see. They look like different. So when you have this kind of feeling in your clinical aspect, you say, what's this? I don't know this disease. Then it's time to think about it. That's what I would say. Marie-Paul, would you agree?
I agree also. Thank
you. Rosie, do you have any additional comments to make here? So thank you very much. I think just a note that the CPS is working on guidelines right now for some guidance as we go forward, and we will look forward to hearing those guidelines. So please stay tuned. Lots are being learned right now. Second group of questions actually relates to genetics and environment, and the thought of why is it that there's children from Afro-Caribbean populations are much more affected. Given the fact that in Kawasaki disease, it's usually not that way, but it's much more the Asian populations. Maybe I can ask Dr. Skuchmari to comment on this.
So there are a few thoughts. One of the thoughts is possibly an association with a vitamin D deficiency. This still has to be clarified, and certainly research studies moving forward will need to look at that. Certainly in regards to genetics, this will be important in terms of investigating. Certainly, we know with Kawasaki disease, there are different genes that are at play, and maybe there's a different set of genes at play that's being turned on with the coronavirus. That again will have to be clarified. Afro-Caribbean is a higher group of children who are affected with Kawasaki disease, especially in North America. It's not only Asians. However, there's also theory that potentially that the SARS-CoV-2 has mutated from the Asian type to a European type, and in North America, we're seeing more the European type. This is again theoretical, so everything is still very theoretical. Whether genes are at play, whether the SARS-CoV-2 has mutated to a different, slightly different type, and thirdly, whether there's other environmental such as vitamin D deficiency.
Thank you very much. In the interest of time, it's now 12 o'clock. I want to thank all the speakers again for their wonderful presentations, and also to answer many of the questions. This webinar is recorded, and I will turn it over to our hosts to tell us about that. Thank you very much.
Thank you so much, Ray, Rosie, Ellie, Mary, Paul, and Roberta. And thank you all those in attendance for your interest in this webinar and your patience as we experienced audio issues, likely related to us all working remotely now. Typically, Children's Healthcare Canada hosts our Spark Live webinars every Wednesday at 11 a.m. Eastern. However, during this COVID pandemic, we're also offering special editions of some of our knowledge sharing opportunities. These may fall outside our typical webinar slots. To stay up to date on all of our activities and events, please sign up for our Children's Healthcare Canada Spark newsletter if you have not already done so. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't watch live, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. Tomorrow, May 28th, we have two offerings. At 11 a.m. Eastern, we are pleased to bring you best practices in family engagement and partnership with our colleagues from Holland Bloorview. And at 7 p.m. Eastern, we're hosting a fireside chat with families led by Dr. Nora Fayed and Ray Martin, titled, How Are Canadian Families Doing with Home Care and Medical Technology for Children with Medical Complexity During COVID-19? Next week, we also have more webinars coming, the first of which is Wednesday, June 3rd at 11 a.m. Eastern, when we're partnering with our colleagues in SKIP, the Solutions for Kids in Pain, to bring you Mobilizing to Virtual Care, Experiences of Sick Kids Chronic Pain Clinic, with our members from Sick Kids Hospital. So thanks again for joining us today. Thanks to the Canadian Paediatric Society and Children's Healthcare Canada members for supporting our webinar program. And hopefully we'll see many of you back here tomorrow. Bye, everyone.